Thank you for joining our Debbie's Dream Foundation Curing Stomach Cancer webinar series. Today's webinar is on the NCCN Guidelines, Treatment Decisions in Stomach Cancer, and it is the fifth in a series of 12 monthly webinars. I'm Mary Margaret Kilmeyer, and I'll be moderating today's webinar. I'm the Programs Director for Debbie's Dream Foundation Curing Stomach Cancer and a licensed marriage and family therapist. My clinical and research background is focused on working collaboratively with doctors, patients, their families, and members of the healthcare team. We would like to thank our title sponsor, Boston Biomedical, and our platinum sponsor, Lilly Oncology, for providing the funding to make this webinar possible. You will be able to ask questions during the presentation by typing your question into the white text box that appears on your screen. We will address all questions at the conclusion of the presentation as time allows. In addition, this webinar will be recorded and accessible on our website in the lecture library section. First, I will share information about our president and founder and the organization, Debbie's Dream Foundation. Then we will hear a presentation on the NCCN Guidelines from Dr. Benson of Northwestern University and conclude with a question and answer session. Pictured here is the president and founder of Debbie's Dream Foundation Curing Stomach Cancer. Debbie was diagnosed with stage 4 stomach cancer in April of 2008. She was a practicing attorney and mother of 3, and she had no risk factors for stomach cancer, and her symptoms were very vague. At the time, she was told that her chance of being alive in 5 years was only 4%. She has endured harsh chemo regimens and targeted treatments and has experienced many recurrences over 9 years and is still a patient to this day. Debbie founded DDF in April of 2009, and as an organization, we are a member of several advocacy coalitions, including the Deadliest Cancer Coalition, the Patient Equal Access Coalition, the State Patient Equal Access Coalition, and One Voice Against Cancer. Debbie also serves as a patient advocate on numerous committees and task forces. Some of you may be familiar with the facts and statistics about stomach cancer, and they are continually being updated. In 2017, it's estimated that more than 28,000 Americans will be diagnosed with stomach cancer, and more than 11,000 will die that year. 80% of all stomach cancer patients are diagnosed at stage 4, when the 5-year survival rate is only 5%, and the incidence rates in younger populations is increasing, and the expected frequency has been on the decline. Yet many people know very little about this deadly disease. Debbie's Dream Foundation is dedicated to raising awareness about stomach cancer, advancing funding for research, and providing education and support internationally to patients, families, and caregivers. Our ultimate goal is to make the cure for stomach cancer a reality. You can learn more by visiting our website at www.debbiesdream.org. In the few short years that DDF has been in existence, we've achieved many great milestones. We have 27 chapters across the United States, as well as chapters in Canada and Germany. There are events that are ongoing around the country all year. Our patient resource education program helps patients, their families, and caregivers around the world by matching them with survivors and caregivers using disease-specific criteria such as stage, biomarkers, and location. We host webinars and symposia year-round, and our website contains in-depth information about stomach cancer that can be translated into more than 60 languages. We have also provided $650,000 in direct research grants and advocate every year during our Capitol Hill Advocacy Day to add stomach cancer to the Department of Defense's peer-reviewed cancer research program, resulting in more than $5.8 million being awarded to stomach cancer researchers. Here you'll see a snapshot of our homepage with links to numerous resources, including our online stomach cancer support community, and many of the events that we have on the horizon, including our teams participating in races and runs, such as the Chicago Half Marathon and 5K. In September, the annual Dream Big Luncheon will be celebrating Debbie's 50th birthday on the 25th of September in Weston, Florida. There are golf tournaments in November in both North Carolina and Florida. In addition, the month of November is known as Curing Stomach Cancer Month. Please see our website's advocacy page for more information to declare this in your state. And for more information about these and other events, please check out our website and click on Events. DDF is headquartered in Plantation, Florida. Our office hours are Monday through Friday from 8 a.m. to 5 p.m. Eastern Time. Also on this slide, you'll see important phone numbers and email addresses you can use to contact our office and staff. We will now begin the presentation, made possible in part by our title sponsor, Boston Biomedical. The topic this month is the NCCN Guidelines and how they impact treatment decisions in stomach cancer. Our speaker is Dr. Al Benson of Northwestern University. Dr. Benson is a professor of medicine at Northwestern University's Feinberg School of Medicine, as well as an associate director for the clinical investigations at the Robert Lurie Comprehensive Cancer Center and an attending physician at Northwestern Memorial Hospital. Dr. Benson serves on numerous professional committees, including being an executive committee member and past chair of the board of directors at the NCCN. We're pleased to know that Dr. Benson also serves as a member of the Medical Advisory Board of Debbie's Dream Foundation. And so at this time, I'd like to turn the webinar over to you, Dr. Benson. Thank you so much for joining us today.
Thank you very much, Mary Margaret, and thanks to all of you for joining today's webinar. Cancer treatment guidelines are becoming increasingly important to help guide both clinicians and patients in making decisions as to how care, including diagnosis and overall management for patients who are diagnosed with a given cancer. Given the increasing complexity of cancer medicine, the fact that we are developing, for example, genomic profiles to help guide treatment decisions, and the fact that the FDA is increasingly approving more and more drugs to treat cancer, you can imagine that with this level of complexity across various cancers, guidance tools are very important to help keep people up to date and help people make the very best decisions relative to cancer care. I'm going to talk today about NCCN guidelines and how these guidelines are integrated into decision tools both for patients and clinicians. The NCCN is the National Comprehensive Cancer Network, and last year we celebrated our 20th anniversary. The NCCN consists of 27 of the leading cancer centers in the United States, and through many, many different panels across disease sites, as well as panels that review issues such as symptom management, the NCCN has developed guidelines that are constantly updated and used not only by patients and clinicians, but also by insurance agencies, including Medicare, to give guidance for cancer care reimbursement. In fact, NCCN is truly global because around the world, clinicians routinely refer to these guidelines to help direct patient care. Next slide, please. For those of you who would like to access the website, it's nccn.org. This is free of charge, and this not only includes the guidelines that clinicians use, but there are also patient treatment guidelines, and I'm going to be showing you some of these guidelines as they relate to gastric cancer a little bit later in this presentation. Next slide. This just shows you the map of the institutions that are members of NCCN, and you can see we cover the entire United States, so that many patients have access to these centers across the country and to the products such as the NCCN guidelines that these centers help produce. Next. So I want to talk a little bit more about the process of guidelines because I think it's important for people to understand how they're created and how they're used. So there are two main types of evidence-based guidelines. One type is a process map of interventions over time. So this looks at a continuum of care, so the guideline can address the coordination of care. In these type of guidelines, because they literally can involve thousands of decision points in terms of a spectrum of care for a patient, there may be fewer references for each decision. And so many of these guidelines not only use evidence, but they also use consensus on the part of the clinicians who participate in the creation of the guideline. And then there's another type of guideline, which is referred to as a systematic review. This type of review focuses generally on a single treatment issue, for example. So it's much more restricted. It likely addresses perhaps just a single decision point in terms of the spectrum of care for an individual. But it's also a very exhaustive, comprehensive review of the literature. Now, often the first type of guideline that I reviewed references a systematic review. So if there's been a very exhaustive review around a single issue, it can very much help inform what goes into a much broader treatment guideline. Next slide. So one of the problems we currently have, although in medicine we're constantly generating evidence to support our decisions, the reality is that there are often many gaps. So what you can see shown on this slide is blocks where we have evidence, but you can also see in between these blocks there are often gaps. And so what a guideline such as NCCN tries to do is present the evidence, but then also, because the gaps can represent very important real-life treatment decisions and care decisions, by consensus, we try to give guidance where evidence may not be as robust, but yet it's important to provide guidance for an individual patient in making a decision in terms of their care. Next slide. And this just shows you how we try to fill in the gaps with expert consensus. Next slide. So in terms of looking at a quality health care, this is really the degree to which health services for individuals and populations increase the likelihood of desired outcomes and are consistent with current professional knowledge. So part of the goal of a guideline is certainly to improve the quality of the health care delivered, to try to reduce variability that may not be appropriate. Let's go to the next slide. So why high-quality care matters? Well, for example, it's possible to have too much care where there is overuse of a given therapy. And if there is overuse of a therapy, this can add to toxicity as well as morbidity and mortality. And it also represents a waste of important resources. On the other hand, if there's too little care, this can reflect an underuse of therapy. And so the potential benefits for the individual are not achieved. And it also fails to use resources appropriately. We certainly don't want wrong therapy. Not only does that add to toxicity and waste resources, but there is a much lower likelihood there will be any benefit for an individual patient. And of course, we want people to receive the correct therapy that can optimize the benefits of the treatment. Correct therapy is a balance between toxicity versus the benefit of the treatment, and it is the best way to use resources appropriately. Next slide. In terms of when the U.S. Institute of Medicine tried to address this issue of quality of care and guidelines, what they emphasize is the need to systematically develop statements to assist the practitioner and patient decisions about appropriate health care for specific clinical circumstances. And this is exactly what a guideline is intended to do. Next slide. So there are several key points that are important to remember about a guideline. Guidelines are not prescriptions for care. They are truly a guidance tool to enhance not only clinicians' understanding of a given disease and the appropriate options for management, but also should enhance the discussion between the patient and the clinician so that the patient is best informed about what might be available for care, what would be appropriate considerations of treatment, and also provide choice for the individual patient where appropriate. And it is important to emphasize that the choice is a dynamic between the clinician and the patient, and of course, often family members are involved in this process. Medicine is not static, so this is an evolutionary process. So what's very, very important about a guideline is that it's constantly updated. And one reason so many people reference the NCCN Guidelines is that our panels constantly meet and update the guidelines in real time. And since it's free on the internet, this is quite easy to update on a regular basis. Also, in the case of NCCN, it is designed to be comprehensive, to include what is known about treatment for a given clinical situation. This can differ from a pathway where choices of treatment may be narrowed based on a number of other selection criteria, but may not necessarily be a comprehensive list of what might be considered appropriate choices for treatment. I talked about decision points, that there are often thousands of decision points per disease. So if you look at the breast cancer guidelines, there are over 500,000 different pathways for treatment considerations. For non-small cell lung cancer, 50,000 pathways. So you can imagine how complicated this is, and the real need to try to develop a process that's easy for clinicians and patients to use as a reference tool to help inform decision making. And also, there is such increasing pressure now to address value and cost. And these guidelines can be a valuable resource to help people understand what is really known about a treatment, a given treatment situation, and to try to choose the very best option to provide the best value for the individual patient. There's also what's called a 5% rule. So if a given situation occurs less than 5% of the time, it's very, very difficult to create a guideline. However, with the increasing use of genomics and trying to match patient treatment strategies on the basis of human tumor biology, this may change because we're increasingly learning that there are subsets of patients with a given cancer where their particular disease subset profile may only occur 4% of the time for that disease, yet we are able to develop treatments on the basis, for example, of looking at tumor genomics that may be very, very valuable for that individual. And so cancer treatment guidelines now are including genomics wherever they apply to help inform patient decisions in terms of their treatment. Next slide. In terms of the rationale for these guidelines, first, the evidence is evaluated and recommendations are made by true multidisciplinary experts. So this includes surgeons and radiation oncologists and pathologists and medical oncologists, for example, who are truly expert in treating a given disease. These are objective and an explicit decision-making process. As I mentioned, one component of this is to try to minimize variation in care, to provide a standard of care for quality assessment. And also, this does help insurers, for example, because they can readily assess the appropriateness of care. And these guidelines also can help in clinician education. In medicine, it is vitally important that people are kept up to date. And so very experienced clinicians need constant education. And certainly for our medical students, residents, and fellows, these guidelines can serve as an important education tool for them also. Next slide. Just to quickly reiterate that this is a very explicit process. Evidence is used when available. The level of evidence is clearly identified. So in some cases, we have very high level of evidence with multiple clinical trials. In other situations, less so. I emphasize that they're multidisciplinary with experts and that we do manage conflicts of interest. People's various associations are clearly stated, and these are updated frequently. And plus there is the inclusion of supporting documentation so people know exactly where the evidence is from with appropriate reference. Next. And this just shows the variety of the types of healthcare professionals who compose these guideline panels. Next slide. In terms of using evidence to make a recommendation, first of all, there can be data from many different sources, including multiple types of studies. And these are kind of siphoned by expert evaluation. So in the end, in reviewing the evidence, we can distill appropriate recommendations. And also, because I stress that this is evolutionary, in this process, we have to constantly look at new studies, because as new studies emerge, these studies may actually change the standard of care. And if that happens, the guidelines have to reflect these changes. And so this is a very constant system. Next slide. And this just shows you how such a process can work. So I mentioned in NCCN there are the panels, which consist of about 27 members, representing each of the 27 institutions, but these guidelines are also independently reviewed at each institution by other experts, and their comments are then sent to the panel and to the NCCN staff for review and incorporation in discussion in terms of each guideline to determine, is the guideline current, is revision needed, and certainly if there are new treatments, should these get integrated. And then these guidelines, once these reviews and updates are completed, they're published and available online. Next slide. I mentioned that there can be categories of evidence and consensus. So category 1 is the highest level of evidence, where there's uniform consensus that the intervention is appropriate, and often in this situation there are multiple clinical trials that demonstrate the true efficacy of a given treatment. Category 2A is there's lower level of evidence, but there's pretty uniform consensus that the intervention is very appropriate. And for a 2B, there is still consensus that the intervention is appropriate, and it's based on lower level of evidence, but a little less so. Very little is category 3, and you'll see in the guidelines that there's very little category 3 recommendations, because here there's really disagreement if the intervention is appropriate, and generally in such a case it's not encouraged to utilize that given treatment or approach. Next. Unfortunately, I should add, in medicine our evidence is such that only a minority of decisions are based on category 1 level of evidence. Most levels of evidence fall in the 2A category. In terms of application of guidelines to patient care, it's important to know that guidelines are applicable to most but not all patients. So we recognize that patients are very much individuals, and they may have a situation that might fall outside a given guideline recommendation. And so understanding an individual person's clinical situation is very, very important and must take into account, do people have comorbidities or other illnesses that could influence, for example, the choice of treatment. So, for example, if someone has significant neuropathy, say from diabetes, well, you would want to avoid a drug, even if it's strongly recommended, that may aggravate that neuropathy. Understanding the patient's status and certainly getting a sense of the individual patient choice is critical in making a treatment decision. So that's why I emphasize a guideline is a tool to help inform a decision-making process between the individual patient and the clinician. Next slide. What these guidelines do, they follow decision-making algorithms, and I'll show you examples of that. They offer a range of appropriate treatments for specific situations, and as I constantly emphasize, we want to decrease variability to give the most appropriate care for each individual patient. Next slide. And this gives you an example of what we refer to as the continuum of care. And so the continuum of care starts with prevention and screening, and then moves on to treatment and recovery and surveillance, and then over time constantly evaluating the patient to make sure that there's no evidence of recurrence, and if there is recurrence, to look at other therapeutic options to help that individual patient treat that recurrence. And then there are also important issues in the cancer cancer care continuum of survivorship. For example, looking for long-term effects of treatment that may adversely affect an individual's quality of life and how to intervene and help a person in that situation, but also a time when hospice care may be the most appropriate option for that individual person. So this is very much a continuum of care, and guidelines such as NCCN attempt to address this continuum. Next slide. So the other point of great importance here is clinical trial participation. And so throughout the NCCN guidelines, we recognize that we often have insufficient data to support many decisions in oncology. As I mentioned before, we have a lot of gaps in care, and we have to develop ways to fill in those gaps. And we also recognize that even if we have effective treatments, we want to develop more effective treatments. And the only way we can do that is with clinical trials. And so clinical trials are always a component of a guideline algorithm. Next slide. And there has been a lot of in and people really follow a guideline. And here's an example of gastric cancer where in this research project, they identified patients who had care, meaning that compliance with NCCN guidelines and stage-specific therapy, that there was a significant improvement in outcome. And what we have seen in other diseases is that this also seems to be true, that people who are treated with the most modern concepts as reflected in guidelines tend to do better. And so it's one of the reasons, among others, that I've mentioned that guidelines can be important. Next slide. There are exceptions to what we call guideline concordant care, and I've mentioned this a little bit previously, but we must always use clinical judgment when applying guidelines to the individual. After all, we are addressing very much individual people. And as I said, guidelines only apply perhaps to 80 to 85% of all patients. And there are clinical situations that don't fit guidelines. Physical status might limit the desirability of a certain treatment. Comorbid conditions may mean that there's a contraindication to using concordant care. And of course, the patient, in the end, must decide if a given treatment is really right for that individual. Next slide. Now, another aspect that's been developed in the case of NCCN, and this is also a tool to help guide decisions between the individual patient and the clinician, is looking at a given regimen or a group of regimens to see efficacy, how well does the treatment work, safety, the quality of the evidence, the consistency of the evidence, and affordability. And by looking at this block, you can see that at just a quick glance, you can get a sense of what's known about a regimen. So in this particular case, for example, if you look at the quality of evidence, it's very high quality of evidence. And the efficacy of the evidence in this case is not bad, although there may be some safety concerns, that there may be toxicities of concern, and that it's a fairly affordable regimen if we just look at this type of block. Next slide. And so the way this is incorporated, this just shows you an example in gastric cancer of a variety of chemotherapy regimens that we use to treat advanced gastric cancer. And you can see next to each regimen is an evidence block. And so if for a given situation, for a given patient, there may be multiple options of treatment available. And you can use these evidence blocks to try to help inform the decision in terms of the evidence and the safety, and are there very significant cost concerns that might be important for that patient. Next slide. And this is just another example. Next slide. Let's go on to the next slide. So now I want to focus very much on stomach cancer and how these guidelines have served to create tools. And I want to start out with the NCCN Guidelines for patients. So what happens here is the clinical guidelines that clinicians use are carefully evaluated and then translated into what we hope is a very person-friendly tool to someone or their families to better understand stomach cancer in lay language. And so let's go on to the next slide, and I'm going to show you a variety of examples in terms of what's included. And this, by the way, is available online, and if you wanted a paper copy, you could either print it or you can actually order this on Amazon. And I also want to stress that creating this patient-friendly guideline through the NCCN Foundation would not have been possible without Debbie Dreen's foundation contributing to the development of this. And we're very grateful for this level of support and helping make this possible. So here, this is just an introduction in terms of this particular document, emphasizing that when you're diagnosed with stomach cancer, it's often overwhelming, and that we want to create tools that can help guide a person through this very complex, emotionally charged situation. Next slide. And this is just the type of information that you can find in a patient guideline. So it gives the basics of stomach cancer, cancer staging, how to prepare for treatment, overview of treatment, other treatment, how to provide guidance, making decisions, as well as trying to give a glossary of terms that are often used in medicine we might understand immediately. So definitions become important for people to understand. Next slide. Yeah, next slide.
We're just experiencing a little lag in the technology here.
So, as many of you may know, we use what's referred to as the TNM stage. That stands for tumor, nodes, as in nodes, and metastases. And there's both a clinical stage which we determine by, for example, x-rays or endoscopy, maybe then physical exam. And then there's the path. Stomach cancer is grouped into these stages, and there are 5 stages for stomach cancer, and certainly we've learned the earlier the stage, the better the outcome. And I already talked about clinical and pathologic staging. Next slide. So in terms of cancer tests, it's 18. Important for people to know what kind of tests they may require, and certainly we emphasize that the medical history is critical. So it's very important for people to communicate with their healthcare team so they fully understand their past medical history and their life circumstances in addition. We also try to identify various risk factors that may predispose a person to stomach cancer, and certainly we're looking for any situations where it may be inherited, which could affect other family members, and that's all part of gathering information through the medical history. Next slide. And here, this tries to give a graphic as to what is an upper endoscopy and the ability for the gastroenterologist to get a very detailed look at the stomach, and also provides the ability to do biopsies for diagnostic purposes. But you can see on the left there are a variety of tests that we consider when we are evaluating a person, and much of this evaluation is to determine, is this an individual who either immediately or perhaps after initial therapy would be appropriate for surgical removal of the tumor. And so these tests are designed to give us as much information as possible. Next slide. We also emphasize that the treatment of stomach cancer is typically multidisciplinary, and this lists the type of clinicians who are very, very important in the assessment and ongoing care of someone with stomach cancer. And we also emphasize nutrition, and that there may be the need not only for consultation, but if an individual cannot adequately provide nutrition for themselves by eating normally, there are techniques where we can help guarantee that that individual has appropriate nutrition. So this is a very important concept in terms of evaluation and treatment of individuals. Next slide. Here we also talk about this concept of targeted therapy. Most people have heard the phrase chemotherapy. These drugs are often not as specific as we would like them to be in terms of identifying a very specific tumor pathway, for example, that helps the tumor grow, but have been shown to be effective effective by doing, for example, clinical trial investigation. But targeted therapies are not chemotherapy drugs, but they're what we often call biologic therapies that target a specific biological pathway within a tumor. And so gastric cancer, one of these biologic pathways is referred to as the HER2 pathway, and we actually have a drug, trastuzumab, that can be very helpful for patients who have HER2 positive stomach tumors. And there are other pathways that I don't have time to elaborate upon, but these biologics are increasingly integrated into the care of patients with stomach cancer, and we try to explain this in this guidance tool. Next slide. And this talks about the HER2 pathway and trastuzumab, so you can see we try to give better explanations as well as informing people what the possible side effects might be. Next slide. Here again, we emphasize clinical trials, and we try to give a little bit of background so people understand the various phases of trials. So there are phase 1 trials that are often highly experimental, but in fact, the best option for an individual person. And then there are far more advanced trials where we may be comparing a very promising new approach based on earlier clinical trial data to a standard of care regimen. And sometimes we're comparing multiple different regimens to see if one comes out on top as the very best to offer patients. Next slide. We also talk about some of the various tools we have. So there are tools such as endoscopic resection. So for very early tumors, the gastroenterologist may be able to use that endoscopy to remove the tumor, and patients may not even need more surgery. And then it describes a gastrectomy and also the concepts of radiation therapy and, again, chemotherapy. Next slide. We also emphasize supportive care, and what we call performance status score is very, very important. And this gives us a sense of how well is an individual functioning. So a person who has a very good performance status, high level of functioning, is in a situation where they're most likely to respond to therapy and also perhaps better able to manage any side effects. Whereas if a person is doing very poorly, it becomes less likely that a given treatment will help them. In fact, it's possible it would make them worse because of potential side effects. And so the evaluation of an individual, which is certainly an ongoing phenomenon in terms of performance status, is very important in making decisions. Next slide. And this just talks about performance status, and it gives examples of the two principal measures we use clinically to define performance status, and also talks more about supportive care. Now, supportive care is also important when patients are receiving treatment because there may be side effects, there may be other situations that require intervention, and so we have to pay a lot of attention of how we can eliminate side effects, for example, from chemotherapy, or better control them. So supportive care is really multifaceted in terms of its meaning. Next. And sometimes people talk about supportive care as palliative care, and by that we mean maximizing symptom control, and helping patients enjoy the highest quality of life possible, whether they're on treatment or not. Then this guidance tool also provides the various chemotherapy regimens, and you can see our expert panels try to define regimens that are preferred, but that there are other regimens that may be very appropriate for a person, and in fact, there may be a choice made for an individual looking at some of these other regimens. Next slide. I think we can go on because this also includes regimens for second line. Here's some more information on symptom control, including if someone had a GI blockage or bowel obstruction, which is something we have to be very aware of, and some patients are at risk for this. Next slide. And then we talk more about systemic therapy and side effects in clinical trials, as well as HER2 testing. Next slide. Let's go on to the next slide. And so here is this whole section about it is your choice. And this tries to give you guidance in terms of how you might choose to make a decision and how you can best communicate with your clinician. Next. We can go on to the next. And also important here, related to choice, is questions to ask your doctors. So there's a series of questions here. For example, what's my diagnosis and prognosis? And this gives you a guidance as to what kind of questions you might best address with your clinician. Next. What are my options? And again, a series of questions that will give you guidance to give you an opportunity to best interact with your cancer team. Next. What does each option require of me? This is really important because you need to know, do you have to be in the hospital? How many times do you have to come to the outpatient office? There are a whole series of questions where you might not think of them right up front, but this is a guidance tool to help you. Next. And also, you can ask your clinical team, what is their experience? And this gives you questions how to ask. Next. And weighing your options, a variety of points here, also discussing second opinions, various support groups that might be available, and also how do you weigh the pros and cons in terms of a treatment decision. Next. And then I'm just going to conclude because we want time for questions, just to show you what I've just reviewed is what's available for you based on cancer treatment guidelines and expert opinion in creating a patient-friendly tool. This you can also see online, but this is what the clinicians use. So let's go to the next slide. And this is just an example of an algorithm. So this is a situation when a person is first being evaluated for stomach cancer. So you can see that the workup includes a variety of critical factors, and also these factors have been integrated into the patient guidance tool that we just reviewed quickly. You can see here then we talk about clinical stage and how the clinical stage will help determine what is the next step. And the next step may well include additional evaluation. You'll also see in the guidelines we're reminding clinicians, is the individual what we call medically fit? Are these individuals who could withstand surgery, for example? Understand what is their comorbidity. And you'll also see in the far right, we mention multidisciplinary review, emphasizing that the care of an individual patient, it really requires a whole team of experts. Next slide. And then this just carries through in terms of if people are surgical candidates or not, and then what is the final pathologic stage or based on the findings, and then, most of that would be the primary clinical stage, and what is the best primary treatment, whether they should get chemotherapy and radiation, for example, or if they should go directly to surgery. Next. And then after surgery, you see that we then obtain the pathologic stage, and from that pathologic stage, make a decision whether an individual should receive additional therapy. And these algorithms continue for a variety of situations, including people with metastatic disease or recur or who are under surveillance. And at the end of this series of algorithms is a very detailed manuscript that gives a great deal of information about gastric cancer and provides the evidence that supports these algorithms. And now I think we better take a few questions. I think I ran over a bit. I'm sorry for that. There's a tremendous amount to cover, but I wanted to at least give you a sense of the tools we have and how these can help both patients and clinicians alike.
Thank you so much, Dr. Benson. I know that was a very comprehensive review of the guidelines and treatment decisions, and yet there was still so much more to discuss and share. I just want to make mention again, as you had said earlier, that the patient guidelines, for anyone listening in, you can go to the NCCN website and download a copy of those, or you can order them online as well. So we're going to go ahead and take a few questions that we received during the presentation. And the first one that comes in is actually, Dr. Benson, to ask, how would you recommend a patient facilitate conversations about treatment decisions using these guidelines? What is the best way for patients to do this?
Well, that's a really important question because, you know, often when people go into the room to talk with their healthcare team, they're often nervous, they have a lot on their mind, they're often scared, and a lot is happening at once, and it's completely overwhelming. So it is very helpful before the office visit to have a written list of questions. And so if you look at the patient tool we've been talking about, part of the purpose of that is to help you formulate those questions. And that also it's actually very helpful to the clinician, because then the clinician knows what is on the mind of this individual person. What is their greatest concern? What do they really want to know? And this isn't just a one-stop process, because it's often said that an individual retains about 10% of what the clinician just told them. And that's very understandable. It's a different language. Some of this is, as you can see here, what we just talked about, it's immensely complicated. So actually taking notes while you're meeting with the clinician is important, and that will help you formulate questions in the future that you'll want to bring back. Or you may think you've heard something, but then you don't really understand it. Maybe it wasn't clear enough, and you need more clarity. So using a tool like this can be helpful to formulate your questions. And also, importantly, bring someone with you. A second pair of ears is often very, very important.
I definitely would agree with that, and it's something that we recommend for patients as well. Another question that's just come in is regarding the complementary and alternative treatments. How are those incorporated into the guidelines and decision-making for both patients as well as the physicians?
So many of our centers do have integrative health programs. One of the problems with integrated health is there's often not the full evidence to actually be able to create a guideline. However, in some of the symptom management guidelines and so forth, there may be mention of like acupuncture, things like that, ways to address pain, for example. So currently it's quite difficult to create a guideline because we have such limited evidence with the efficacy. But at Northwestern we refer people to our integrative health program where some of these other options are addressed with people. But I would say it's important for people when they meet with their clinician, if this is something they're very interested in, to talk about it. And there may be resources available for the individual person who would like to explore some of the alternatives that might be available.
Great, thank you. And I know we're coming right up on the hour, so I'll take one last question, which is regarding prevention and screening. The guidelines for the treatment, of course, began with the diagnosis, but is there anything in place regarding prevention or screening prior to development of the cancer diagnosis?
So we do have screening guidelines in NCCN. The problem with a screening program for gastric cancer is that it's not all that common in the U.S. So you would have to screen, millions of people literally for a diagnosis. However, there are people who are at risk. So there may be people with inherited syndromes like Lynch syndrome where it's very important that people get linked to genetic counseling and make sure they don't carry a genetic risk. One of the problems with gastric cancer is the symptoms may be fairly vague, and people may not be thinking of a gastric cancer. So it is a little bit more limited in terms of an actual screening program, but there are people at known risk who should be screened, and that is addressed in the screening guidelines.
Great. Well, thank you so much again for taking the time to respond to those questions, Dr. Benson, and for joining us today. We appreciate the time and effort put into the presentation.
Thank you.
And for everyone listening today, as you know, the webinar was brought to you by Debbie's Dream Foundation, Curing Stomach Cancer. Thank you again to Dr. Benson for joining us and providing us with this vital information. The recorded version of this webinar and our past webinars can be found on the lecture library of our website. I'd like to again thank our title sponsor, Boston Biomedical, and our platinum sponsor, Lilly Oncology, both of whom provided funding to make these webinars possible. Just as a reminder to please check our website and your calendars to join us for an event that will be near you throughout the year. And I'd like to thank all of you for listening today. This concludes our 5th in a series of 12 webinars. The next webinar will be hosted on July 28th at 12 noon Eastern Time. And again, to review recorded webinars, please visit our website. Before July 28th, we'd love to hear your feedback, questions, and thoughts. please send your comments to patient.resource@wstream.org. Thank you for joining us.